Are you actually going to do a demo? You're actually going to put something up? Okay, good. Good.
Okay, we are live.
Great, Tony.
Good morning, everybody. Thank you for tuning in to our staff meeting of today, August 11th, 9 o'clock. So welcome. Tom, what do you have for us?
Good morning, Chairman and Commission. A COVID update today is the main focus of the staff meeting. We'll go through a quick dashboard review and just kind of look at some trending of numbers. And then Tim will come up and talk about the current status of testing, how the drive-through on Edgemore is working, and the plans for the mobile unit. He will also give an update on some software that we're looking at to better automate the system so that people can sign up for their own testing and maybe get some results back without all this telephone calling going on back and forth. So he'll give you an update on that. Adrian will talk about any staffing or operational issues, and then we'll be available for questions from the commission. So if we look at the dashboard this morning, there's some numbers that are beginning to trend better for us. Our infection rate numbers are down to around the 10% range, which is an improvement over the 14% positive ratio that we were seeing just a few days ago. Then our hospital numbers on our call, and I had emailed you all yesterday, look a little bit better this week. The number of admissions went down from 72 to 64. Our ICU bed numbers went down about a half a dozen. We will have to, there's one number we'll modify on the board today. I'll get with Jack. There is the availability of ICU beds should be at 182 and not 188. The hospitals indicated yesterday that they're seeing consistency in their ICUs, so we will make one small alteration on that number. But the hospital report yesterday across the board from all three was better this week than it was last week. The VA numbers, who never have had big numbers, have gone down. And even our report from McConnell Air Force Base was a little bit better than it was last week, less incidence of virus. So something's going right. The numbers are beginning to come down a bit. And if we see decrease again next week in the hospital call, we'll change that yellow to green again the way we had it a few weeks ago. So hopefully we get the same kind of good news from them next week.
Tom, excuse me.
Yes, sir.
Commissioner O'Donnell has a question.
Yes, sir.
Thank you. Is there any way for the hospitals to say how many of those residents live in Sedgwick County?
They do, sir. And we can make that part of this report somehow.
That'd be very helpful.
They do
I
give
think.
that to us. I've just not put it on the dashboard.
Right.
Yeah.
I do think that'd be helpful just because we are a regional hub.
Correct.
For,
Yeah.
which we should be very proud of, but not all those residents are residents of the greater Wichita area.
That is correct. And I would just guess for you as a globally, about 3/4 of the patients are Sedgwick County and about 20-25% are coming outside.
So yesterday at Via Christi, 78% of the 35 people they had were from Sedgwick County. Wesley didn't give the Sedgwick County numbers yesterday.
We'll get that, make that part of this report.
Thank you.
And then just our testing numbers. We are in pretty good shape on PPEs. And here's the graph that scales the number of cases versus recoveries. We've talked the last couple of weeks about recovery numbers. I might have, when Adrian gets to the podium, talk about that. I don't know if we're caught up with making those telephone calls or not, but that recovery number is contingent upon a connection, a physical, verbal connection between health department and person who has COVID, and I don't know that we've been able to keep up with that. I'll let Adrian address that when she comes up. It is possible. We have talked about removing that recovery graph. Some people like to see it though, so we've left it remain, but that's however the commission wants to move forward. And then this active cases is based on that recovery number, so if the recovery number is not clean, then this number also is not the best number. So we might think about removing this as well. And remember, this is only cases reported to the government, cases that have a definitive positive test. There are possible cases out in the community clearly that we don't know about. And I think that's really all I want to talk about today. There's on the last page is the the cluster numbers, which we seem like we add a few clusters every week. So any questions on dashboard?
Commissioner Howell?
Thank you, Mr. Chairman. So, Manager Stoltz, you and I talked a little bit yesterday about KDHE data and how it doesn't seem to mesh very well with the county dashboard. Do we have someone in staff that can contact KDHE and resolve some of those conflicts?
Yes, I plan to do that, sir. And Commissioner Howell's referring, we talk a lot about data, but we're talking about the ICU numbers that are being shown on the KDHE website. We have tried to focus this dashboard on Sedgwick County, not the state of Kansas, not the state of Texas, we're trying to focus this board on our region. And some of the numbers that we see on KDHE with regard to ICU admissions statewide seem off to us. They don't seem to, they seem to be low. We get our information directly from the hospital, so that I'm trusting that the numbers they give us every Monday are the best that they can give. And there's some questions on some of the KDHE data. So yeah, we will look into that, sir.
And one of my assumptions, in case it has not been validated yet, but I think that the hospital's reporting, as it was just stated a moment ago, patients, not necessarily Sedgwick County residents, whereas I think KDHE does break it down by county. So that might be some of the explanation, but the numbers from KDHE are quite a bit lower than what we're seeing reported through you
Right.
in the dashboard. So that is a concern. Thank you for having someone check that out.
Sure.
Okay, Tom,
All
thank
right,
you.
Tim, you're up then, sir.
Good morning, Commissioners. Tim Kaufman, Deputy County Manager. Last week, our Health Department staff sampled 1,102 individuals. Most of that was through the drive-through sampling site on North Edgemore. They had 2 mobile outreach events, and the containment unit went out as well. We didn't meet last week. The week prior, the sampling numbers, I don't have them in front of me, they were about 1,200. So we're consistently over 1,000 a week now as we sample. There are 2 mobile outreach events this week, one in Valley Center yesterday, and then in Goddard on Thursday. And we've got our mobile outreach team that is going to be going to Hayesville, Clearwater in the next 2 weeks. And then we'll also be in Wichita for the first time. We've got a site set up for the 27th. All of that information is on the website. It's available for the community. Appointments are not required at our mobile sites, but again, the population that we're targeting is those that are experiencing symptoms, close contacts of known positives, and then the high priority specialization populations that we continue to sample whether they've got symptoms or not. So those are the first responders, the healthcare workers, and folks like that. That's the population that we're targeting for those mobile outreach opportunities. What we're most excited about showing today, and Kate's going to help me show it, and we've got it up here, is we are going to roll out today for the folks who go through the drive-through sampling site. We're going to give them an opportunity to retrieve their own results. And so in 5 to 7 days, their results will be posted on an external website, and we're using what's known as 2-factor authentication. So people will have something that they know and then something that they have to access that information. So results will come back from the labs. We've got staff that will enter that information into a website, and then the person who's been sampled will have the opportunity to go in and check their results themselves. And so that just shortens that time, hopefully by a day or more, in terms of getting calls made to folks. We'll give someone a document that looks like this as they come through the sampling site. They get a packet of information, a lot of good information about how to stay safe. It includes their last name, which they're going to know. Then what we give them is a passcode, and then they know their date of birth. That way, if this piece of paper blows out of their car window as they're driving home, nobody else is going to be able to retrieve that necessarily, because they're not going to know that date of birth. And so it gives a level of security for folks. And then this is what things are going to look like. So I go get I'm sampled, I wait the 5 to 7 days, I log in at this site, and I'm going to let Kate drive today. And I'm going to put in these 3 identifying factors, and then I'm going to hit search, and I'm going to get a result like this that tells me that unfortunately I'm positive. So I have now information that tells me that I need to isolate, and it gives me some instructions on what I need to do and when it's appropriate for me to return to the wild, the public work, wherever it may be. And then at the end, it also tells me that the health department is going to call and talk about, they'll start that contact tracing, the disease investigation process. So they'll call me and they'll start asking where I've been, where I was before I got my sample, and who I was in contact with, and they'll start to do that investigation process right there. And they will continue to do that throughout the course of my experience until I recover, and tell them that I've been X number of days disease-free and that sort of thing, and then I'll show up in that recovery information. So that's what it looks like if I test positive. The good news is I was negative, so I get the information that tells me this. In my packet, it talks about other information that may be helpful to me in case I live with someone who does have a positive result, for example, that sort of thing. But we also offer to give them a return to work letter. If they need one of those, they can call the health department. We'll generate one of those and send it out to them. And then one of the other options may be that I checked too early. So I couldn't wait. I got sampled yesterday. I get home. I wait till tomorrow. I check. The results aren't entered yet. So it just tells me that the information is not available yet. So we think that this will do a couple of things. One is it reduces the volume of calls that we have to make outbound, and so that's going to help us, as Adrian may talk a little bit about some of the struggles that we continue to have to hire folks, so we don't have to generate as many phone calls, especially those negative phone calls. We still want to talk to everybody that's got a positive result, but this will really cut down on the number of calls that we need to make. You know, as we see, 90% of the results that we're getting back are negative, and so those are going to be hopefully self-retrieved by almost everybody. We will watch to see if people haven't picked up their results, and after a certain period of time, if they haven't picked up their results, even if they're negative, we'll make a phone call and let them know. There's some people that may not be comfortable with this technology, so we'll still make phone calls to folks that need that information. But it's really going to cut down, it should really cut down on the amount of time it takes for people to get their information, particularly those folks that have negative results. So I'd be glad to answer any questions, and I think this is a real step forward. This is a product that was developed in-house. We've got, this is handiwork done by our ITS folks, working with health department folks. We are also in the process of evaluating a couple of different electronic medical records that will give us hopefully the front end, that scheduling piece, a lab manager, and then some results. But we knew that with the skills that we have internally over in ITS that we could develop this part internally as a temporary solution, and so we've got it up and running, and it'll go into effect today. There's people that have already received this today. So,
Commissioner Howell?
Thank you, Mr. Chairman. So if someone logs in and gets the results that are negative, do we keep track of that so that no one from the health department or anybody else needs to make a phone call at that point? I mean, or how do we have
yes,
we're logging the fact that they did log in and receive the information?
right, because we want to call them if they don't check their own results.
Okay, okay, that's good. You said something about the recovery part a moment ago. If someone has met the criteria for recovered, in other words, 10 days after symptom onset with if symptoms, 72 hours after symptoms subside, whichever's longer, and if they have no symptoms, 10 days since test. If they met those criteria and they've considered to be recovered, okay, I guess for the case where it was positive, and then they went into the active column, and then it needs to be moved to the recovered column. Is there anything automated to make that happen?
No, that's where the disease investigators come in, because they're going to continue to talk to those folks and make sure they understand whether or not those symptoms have actually gone away.
Could they not have a way that they could log into that and say, I have no more, I've met these criteria and I have no more symptoms? Could they not give that patient portal a way for someone to log in and make that clear without having to make a phone call?
We can talk to ITS about whether or not that's possible technically, and then we'd also have to talk to the health department about whether that's a good clinical practice.
Well, I'm gonna go back to what I said a meeting or so ago, and I always have to give the caveat because people misinterpret what I'm saying. COVID-19, of course, is a very serious virus. We need to respect it. We need to mitigate the risks through all the things we've been talking about. But having said that, the vast majority of cases, I believe, actually do recover in the criteria that you described. There are some cases that linger, but most people contract COVID-19. The 10 days after symptom onset, 10 days after symptom onset, 72 hours after symptoms subside, whichever is longer, is a pretty good criteria for many people. Most people, I would say, fit the recovery that would fit that kind of description. And if that's true, calculating this just yesterday, we had on the dashboard, it shows 2845 active. Let me do this right. We had 4945 cases. Shows. I'll just say this: 2 weeks ago, 15 days ago, we had 3877. And if I do the math and subtract that out, minus the deaths, we should have somewhere around 1068 active. But we're showing 2845 active, so we're 1,821 active cases off, which is a 64% error. I know we need, I know we need some people to actually to close the loop and move people to the recovered column, but that's not happening in a way that makes the dashboard useful in that part of the dashboard. If there's a 64% error on that, and I'm not saying it's 64% absolutely, but it's probably somewhere close to that, maybe 60%. And having said that, this recovery statistic in our dashboard is not accurate. And I would like to see that there's some way we can automate that, make it a little bit better for someone to say, I've met those criteria, I have no more symptoms, if you were to call me and ask me the very same question, I would tell you I'm recovered. So I don't know that a phone call is absolutely necessary for most people to meet those criteria.
As I said, that's two different factors there. One is technology. We'd have to talk about ITS about the technology to be able to allow them to come back in and enter data into the system, and the other would be the clinical validity of that. It's entirely possible that 10-day average universally is accurate. What I know from the data that the health department staff assessed probably 2 weeks ago, 2.5 weeks ago, the average recovery time on the folks that they were making contact with and connecting with was 19 days. And so if we would double the factor, and I was trying to keep track of your math as you were going, but it seems like if we would double the duration of recovery, potentially going from 10 to 20, it doubles the number of,
Life cases.
or reduces the
But once again, that would be based on symptoms then. So if someone says, yes, I'm 12 days into this and I still have symptoms, they wouldn't check the box. If they said, I had symptoms that ended 5 days ago and I've met all the other criteria, why not let them check a box and say, I have, by your definition, I've recovered, move me over to, and we can essentially allow
Sure,
them to inform us.
Sure, I had moved on from the technology and clinical into the accuracy of the recovered data.
Well, the accuracy right now is woefully inaccurate. I mean, and I love the fact that it's on the chart because I think it's very important for us to track this. This part of our dashboard is important to us as policymakers, but it's incorrect. And I'm trying to improve that. In fact, a couple weeks ago, several weeks ago, maybe 3 or 4 weeks ago now, Director Byrne and I had a discussion about having people opt into a text message to inform them of their test results. And I know there was some discussion about whether that was a good idea or a bad idea. And I think at the end of the day, it was decided it was a good idea. I don't know if we've implemented that, but in order to communicate to people that that their test results came back negative, if that could be done through text messages, someone opts into, this patient portal is even better than that, but we should have been doing this hopefully for a few weeks at least at this point. So someone shouldn't have to wait 7 days or longer to get the results if they were using that. If they have the results and we are lacking someone to make that phone call to let them know that should have been automated hopefully several weeks ago. And we did have this discussion a while back, so I don't know if you're aware of that or not, but okay.
Commissioner Cruz. Oh, all right. Well, Commissioner Cruz?
Thank you, Chairman. So I was trying to follow those numbers. I find it, well, my first question is the data accurate to the best of your knowledge?
Accurate's a difficult, I trust the data. I think I can't tell you that it's 100% accurate, no, but I think that it is.
What margin of error do you think that there is?
I wish I was a statistician and I could tell you precisely. I think that based on what I've seen, and again, it's been a couple of weeks, we had staff do some analysis of what we were seeing in terms of recovery duration and that sort of thing. I would say that it's accurate.
Okay. So I think it's important that we support our staff who's doing this day in, day out, trying to get us the best, most up-to-date, accurate information. And so that, I mean, I've been following this. I know people who have had way longer recovery times than 19 days. So I think that it's important for us to try and support those who are doing the work on the ground. So I'd have to say that, because I think that when we put out, from this bench that the information that we're reporting is inaccurate, what does that do to the confidence of our community? So I really feel like, I feel like we shouldn't be doing that. One other thing that I do want to ask is, so I've received, and just to squash some rumors, I've received a couple of messages around swabs not being actually swabbed and being sent in, and people are having positive results. Can you talk to that a little bit?
I don't know if Adrian
So it's not
is
happening, in
prepared
other
to-
words?
I'm not aware of it.
Okay. So, I did the test. Did you, who all did, we all, I don't think Commissioner O'Donnell did the test, but from my experience, they take out the swab, they use it, they put it back in, and they put it in their collection sample device. So I just want to make sure that people aren't spreading false information about these tests. I think that goes to say, get the whole story, make sure that we're not spreading misinformation, and try to be diligent about the information that you are spreading. I really want to commend you guys for all the work that you're doing. This is not easy when all of these numbers are coming at you. And I'll just reiterate that everybody has this virus. If they do contract this virus, their body handles it differently. So to say that everybody's going to recover after 10 days, I think is an assumption, but one that we can't assume for every single person. So I appreciate what you're doing. I thank you for your continual efforts, and that's it. Thank you.
I think the health department does the staff that work that sampling site do a really good job. I think the staff that we have making calls do a very good job. They work very hard at what they're doing and trying to suppress this. I will point out that we are certainly not the only sampling site in the community. I think everybody in the community that's doing sampling is doing it well. Everybody's experience may be a little bit different. There are lots of different tests out there. I'm not sure that any organization does a really great job explaining the differences between the types of samples that are drawn and the types of tests that may be done on those samples. And so we're in the process of trying to figure out how do we share more information on the website to help people understand. CDC does a really good job of describing the difference between an antibody test and an antigen test and those sorts of things, but it's really hard to get through sometimes. They almost put too much information out there. It's very complicated. So we're trying to figure out how we can help the community better understand all of the different options, and working with some of our partners in the community to make sure they understand all the different testing options that are available, including what we do, whether it's at our drive-through site or at the mobile sites that we do. We've got a testing locator on the website so people can look there, and we're trying to make sure that people understand all the different testing options that are available to them.
Thank you, Commissioner Howell.
Well, thank you. Just want to, clarify. I do appreciate our staff. They have done a tremendous job. This dashboard didn't exist 4 months ago. and it's been a work in progress, and I appreciate the effort that's been put behind it. And I think the people who've done this have hearts of gold. They've done the very best they can. So please understand, I appreciate all the work that's been done, and the health department staff has been second to none. They're the best in this community for all the work that they've been doing in this COVID-19 effort. So let me just express my thanks to them and my appreciation, and say I know they're doing the very best they possibly can. But having said that, there are areas that need to be understood and maybe improved because there's still some challenges out there. So when I say that there were 1,800 people, over 1,800 people, that 2 weeks ago were in the active column that haven't been moved over to recovered, I'm not saying that they all have recovered. That's not what I said. I said if we were to ask them with a phone call, do you have symptoms? No. When did you stop having symptoms? 4 or 5 days ago. And it's the 12th day after their test or after the symptom onset. They should be moved over. If those questions could be asked virtually and automate this in some way, and we could reduce a number that's persistent on our website. The only reason it's up there right now is we don't have staff to make the phone call. That's the truth. And someone please correct me if I'm wrong. We have not had the bandwidth, the people to have the time to make that phone call. And if they had the time, we could probably contact that person and move them over. The reason they're not moved over is because we're busy with other things. And I appreciate that. So I do think this is a relevant conversation. And I've been tested twice, by the way. The last time I got results back, it was 15 days. I know some people say, well, maybe I'm just crazy. That's not what happened. Listen, I tracked that as closely as anybody could possibly track that. It was 15 days. At that point, there's no reason to be tested because I never had symptoms. But 15 days is not useful. So we've got to do better. And that's why the conversation about buying equipment to reduce this time frame is critically important. Getting data to people is critically important, and updating the dashboard accurately is critically important. So having said that, I love everybody. You're all doing a great job, but I just want to highlight an area that, in my opinion, it looks like it's about a 60% error on our dashboard. It is what it is. Thank you.
Okay, thank you, Tim. Anything else? Okay, thank you.
Good morning, Commissioners and Board of Health. Adrienne Byrne, Health Director. So our positions that we had approved in May were 47, and then we had 6 additional approved later on for our mobile team. And out of those, we have 35 hired, and 18 are in the process of being interviewed, set up for interviews, so we are close. Then there were an additional 115 positions that were approved in July, and HR has been busy working with temporary agencies, so they're actually going to be posting, or in the process of posting, 14 of those this week, and the other 101 working with temporary services to be able to get staff on, hopefully a little bit more timely. One of the temporary services said they had over 20 nurses that could start, so we just need to get the final contract signed and then get people on. So we're looking at, as we've talked about before, nursing staff, medical staff have been one of the areas that's been a struggle. Not everybody wants to work on the sampling team. That's been a real struggle, whether it be the mobile team or the drive-through site, because there's still a lot of fear even in the medical community around COVID and sampling. So that has been quite a challenge. But we are getting close to having both of our mobile teams hired so that we're going to be able to be out in the community every day versus utilizing staff that we already have from our TB or clinic programs that could be back in the clinic and TB doing that work, and that limits us to the amount of time we can be out into the community. So we're really excited that we're getting very close to that point. Plan is by the end of this month where we will have both of those teams up and running, so we can really be out in the community, be in Wichita, respond more to the second and third class cities that they'd like us to come back out and sample again. So It takes a long time, a lot longer than, what we'd like, but it's at the same time moving a lot more quickly than what it ordinarily would if it wasn't during COVID times. So speak to the recovery and the active cases, they aren't totally accurate. That is true. And we are always looking at how we can improve. Always. And so that's one of the reasons that we got to this place with the external SharePoint site, and Chantel has been an angel with helping us get to this point where staff can go in and get their own results. So what that does is that frees up other staff that were calling negatives to be entering the data. So when the results come back on EpiTrax, which is the state system for case management, they can take that information and put it on the external SharePoint, which then it frees up the disease investigators who had also been working with that data to get it onto a different like an Excel sheet so that other staff could call negatives. It just is going to start to make that whole process a little bit more efficient. And we have disease investigators that we're in the process of hiring, again, through one of the temp agencies along with nurses. So we are feeling quite optimistic at this point, and more optimistic than what we have in a while because of the number of staff we hear that are waiting to start. So that will free up people to also contact cases to monitor and monitor and manage them. So by the end of the month as well, I hope that graph is up to date. Tim was accurate in the 19 days being the average when we looked at all of the positives, the information that we had. Staff will be working on looking at creating a document that shows just what percentage takes however long with the data that we have. But we are always looking at ways to improve because we know there's always ways to improve, and especially during COVID when we hit the ground fresh with no kind of a roadmap. But yes, I hear what you're saying. And I'll glad to answer any questions.
Thank you for the update on your people hiring. I noticed at the state level, KDHE is contracting with Insight Global for contract tracing. They keep hiring, and is that something that if we were short, have you considered working with KDHE on Insight Global?
We opted into that last week.
Oh, you did?
Yes, we opted into that last week. And so part of the disease investigation, whenever someone is positive and we call them, we still ask them to talk with us about their close contacts, anyone they've been within 6 feet for over 10 minutes. So we get all of that information, even if we aren't doing an active case, a contact investigation with reaching out to those close contacts, we still get all of the information from the person that's positive so that we can have it in that disease management system in case one of them do test positive on down the road. We know who their connection was as far as how they contracted COVID-19. So what the difference is that we have those names in our system and we send them to KDHE. And so KDHE then has these 50 contact tracers who send automated text messages to them asking if they have any symptoms. And if they're not able to contact them through texting, then they pick up the phone and call them. So that's what they're doing, is just to see if they have any symptoms and to encourage them to get tested around day 5 or 6. And if they do begin getting symptoms, then they are tested and would then become one of our cases.
Okay, thank you. I'm pleased to hear that, because you're right. They have 50 contact tracers on staff by August 24th to do this. So I'm glad that we're utilizing that tool. Thank you. Okay, any other comments, questions for anybody? Okay, I don't see any. Thank you, Adrian.
That's all we had, sir. I just might lay out the calendar for the week. We have regular meeting tomorrow. where we will have our weekly CARES presentation from Lindsay. Tanya will also talk about marketing and communications using CARES funding regarding how we are communicating with the community. And Sheena will give more of an update on CARES funding using to hire staffing to manage COVID. In addition, tomorrow Brent Shelton will be here. The external group who is reviewing external expenses with CARES money is now meeting weekly. They actually have an ask for the commission to consider tomorrow, so Brent will be here as well. That will be a second agenda item. And then Thursday, there's a potential of a special meeting. As you all are aware, Dr. Elizabeth Ablaw is researching some options for us. We've spent a lot of time today talking about testing, understanding this is so important as we move forward to improve testing services and decrease that time of notification down to something much more reasonable than 5 to 7 days. She has been working for the last couple of weeks with Wichita State and with Ascension, both of who have plans to help us provide better testing for the community. There's been a back and forth between Dr. Ablaw and those groups. If she is ready to provide her analysis as soon as Thursday, we'd like to schedule that meeting. We will keep you all aware of that movement. If not, we may have to wait a week. I don't think we'd like to do that, but we are hoping to be able to move ahead Thursday. And then also invite those teams into the meeting that you could ask them questions directly as well. Heartland Research has also been in contact with us, Dr. Terry Klein. They have very interesting types of ideas, so I don't want to lose track of them either. I don't know that they don't actually have an application in yet, but they're considering one, so they will also be part of the discussion. But we're focusing right now on Wichita State and Ascension. And Dr. Abloh will hopefully be able to be here Thursday as special meeting. So your canvas is Thursday morning at, I think, 9.
9 o'clock.
And that's scheduled to go to 10:30. So just to give us a cushion, we'll look at an 11 o'clock special meeting time if Dr. Abloh is ready, and I'll keep you aware. So that's kind of the layout for the week. That's all we had today, sir.
Okay, sounds good. Thanks for outlining the remaining week. Anybody else? Any commissioners have any questions? I don't think so. So, okay, we will adjourn. See everybody tomorrow.